Good afternoon and welcome to today's webinar, Setting Clients Up for Nutrition Success While Navigating the World of Weight Management. I'm Leslie Sine, Director of Professional Development at Great Valley Publishing, and I'm the host for today's show. Before we get started, I have 3 points of housekeeping. First, in order to claim your credit, you'll have to remain with us through the entire hour-long presentation. Second, about halfway through and also at the end of our session, our presenters will be taking questions. If you have a question, please use the comments box on the left-hand side of your screen to send your question over to us. We'll try to address as many questions as time allows. Finally, Setting Clients Up for Nutrition Success While Navigating the World of Weight Management awards 1 CPEU in accordance with the Commission on Dietetic Registration's CPEU Prior Approval Program. Based outside of Indianapolis, Heartland Food Products Group is a global leader in the production of low-calorie sweetener products, creamers, beverage concentrates, coffee, and nutritional drinks, all made in the USA. The Splenda brand is the most recognizable and iconic low-calorie sweetener, or LCS, brand in the world, having sold more than 100 billion with a B, yellow packets since its launch in 1991. Today, the Splenda brand supports healthcare professionals, counseling clients to reduce added sugar, manage weight and diabetes, and live an overall healthier lifestyle. Learn more at splenda.com. And now on to our disclosures. Tyler Townsend, MS, RDN, LDN, has the following relevant disclosure to report. He is employed by Heartland Food Products Group, maker of Splenda brand products. Neil Skolnik, MD, has the following relevant disclosures to report. He has received speaking honoraria from AstraZeneca, Teva, Boehringer, Eli Lilly, Sanofi Pasteur, GlaxoSmithKline, Bayer, Novo Nordisk, Heartland Food Products Group, and Astellas. He serves on the advisory boards and is a consultant for AstraZeneca, Lilly, Boehringer Ingelheim, Sanofi, and Sanofi Pasteur, GlaxoSmithKline, Bayer, Genentech, Abbott, Idorsia, Novo Nordisk, and Astellas. And finally, he's received research support from AstraZeneca, Sanofi, Sanofi Pasteur, GlaxoSmithKline, Bayer, and Novo Nordisk. And now we're on to the good stuff. I'm pleased to introduce today's speakers, Dr. Neil Skolnik and Tyler Townsend. Neil Skolnik, MD, is an academic family physician who teaches residents and medical students and sees patients at Abington Family Medicine. He's a professor of family and community medicine at Temple University School of Medicine and an associate director of the Family Medicine Residency Program at Abington Memorial Hospital. He has written and edited 5 books, published approximately 400 columns, articles, and essays, and has given over 200 lectures nationally and internationally. He currently hosts the American Diabetes Association official podcast, Diabetes Core Update, and he has a monthly column on medical guidelines on medscape.com. Tyler Townsend, MSRDN LDN, is a registered dietitian and the Associate Manager of Nutrition and Science Communications at Heartland Food Products Group, maker of Splenda. Tyler's past experience includes surgical weight loss, as well as employer benefits consulting and health data analytics for self-funded employer groups. For fun, Tyler enjoys going to concerts, taking road trips, and spending too much time playing pickleball, according to his wife. And so with all of that, I'm pleased now to turn it over to Dr. Skolnik and Tyler. Welcome to you both.
Leslie, thank you so much for that introduction. And I can say to our audience, I'm so excited to have the opportunity as a physician to talk to a group of dietitians because we have the same goals, but we need to learn how to work more together to accomplish those goals of keeping people healthier and treating their diseases. And the reason why I'm opening up with a picture of 3 infants in front of you is I want you to reflect on whether you, someone you know, a relative, or a friend has had a baby in the last 5 years. And what's really scary to think about is that 2 of 3 infants born in the last 5 years during their lifetime will either be obese or overweight, and 1 of 3 of those infants will develop diabetes during their lifetime. And if we together don't do something to stop this, we're going to talk more about treatment as well in a little bit, but if we don't do something, and the emphasis here really is, it's all about lifestyle. It's all about physical activity. It's all about the right dietary patterns that we can teach our patients, our clients together, then there are going to be continued problems. Because if we look at the rates of obesity over the last 50 years, obesity has gone up by more than fourfold, from about 10% of the United States population to the current rate, which is 42% of United States adults currently have obesity. Another third of adults are categorized as overweight, and the rate of severe obesity is increasing even faster than the rate of obesity in general, and the rate of obesity in children and adolescents. And I've written about adolescent obesity just this past year in JAMA Pediatrics. It is truly a national problem. And if we look at the rate of diabetes, again, we see this incredible increase over the last 50 years to the current rate of 12 to 14% of United States adults have diabetes, and that rate is expected to continue to increase. So together, as clinicians, as physicians, as dietitians, these are critical issues that we need to address. And we have to understand the change in our understanding of obesity. So I'm going to talk about obesity and this new world that we live in of highly effective agents for weight loss, and where that interfaces with our dual need as primary care clinicians, as obesity specialists, and as dietitians to address the dietary aspects while using these incredibly potent medicines. And then Tyler is going to talk about where low and no calorie sweeteners may fit into our approach. We have to understand a change in understanding of obesity. We used to, in the old days, we used to think of obesity as a failure of will, and nothing could be further from the truth. The development of overweight and obesity is due primarily to, in essence, a sick society, a society that doesn't have spaces for physical activity, that doesn't encourage physical activity, and a society where the food industry in many ways has been so sophisticated in its marketing that it's difficult for the average individual to resist the highly processed, high caloric density foods that are incredibly palatable. And that's what leads to obesity. Once you have obesity, though, again, it isn't a failure of will when we don't lose weight. It's a byproduct of the fact that obesity, once one has gained weight, causes all these shifts in hormones and metabolism such that when you begin to lose weight, things like ghrelin, insulin, leptin, GLP-1 shift in a manner to increase the intensity of appetite so that it's almost impossible to resist. And metabolic adaptation occurs so that when we lose weight, our basal metabolic rate goes down, and we begin to, even on a caloric deficit, begin to plateau out and regain weight. So there are three main interventions for weight loss. There's lifestyle, which is diet and exercise. There's pharmacologic. There's bariatric surgery. We're going to cover all of that. We're going to emphasize pharmacologics. That's the area that's new that we need to learn about. So we look at mean weight loss on the range of ways we have to approach weight. When we look at diet and exercise, in formal programs, we get about 7% weight loss here on the left, you see on your slide. When we look at our first generation of anti-obesity agents, things like naltrexone, bupropion, liraglutide, phentermine, topiramate, we get anywhere from 5 or 6% to almost 10% weight loss. But then we enter our modern age of weight loss, and we look at our second generation anti-obesity medicines, semaglutide, and most recently tirzepatide, GLP-1, and tirzepatide, the GIP, GLP-1 dual agonist. We see 15 to over 20% weight loss on the average. And remember, that means half the people lose more than that amount of weight. These are average numbers. And when we look at bariatric surgery with sleeve gastrectomy, we see about 22 to 25% weight loss, with Roux-en-Y gastric bypass over 30%. We are seeing with commonly used second-generation medicines the degree of weight loss we could previously only imagine with bariatric surgery. And that always makes me think of a quote from Spider-Man's Uncle Ben, which is, with great power comes great responsibility. We need to use these medicines wisely, and we need to think about what that means in terms of dietary interventions. So lifestyle, we mentioned 5 to 8% weight loss. Most people who lose weight regain that weight because of increased appetite signaling and a decrease in basal metabolic rate. Diet's an important part of it. Exercise is essential to maintain weight loss. Diet's more important to get weight loss. Let's now talk about what we're going to emphasize: pharmacologic treatments. Semaglutide, the STEP 1 trial. We see 16% weight loss with semaglutide. And when we look at the metric of 10% or more weight loss, 75% of people with semaglutide achieve 10% or more weight loss. We never thought we would see numbers like this. If we look at 15% weight loss, over half of people on semaglutide at the end of a year, at the end of the trial, have 15% weight loss. Mind-boggling. But even more mind-boggling is now the new GIP-GLP-1 receptor agonist, tirzepatide, the SURMOUNT-1 trial that was published in the New England Journal of Medicine. On the lowest maintenance dose, 5 milligrams, we see 16% weight loss. 15 milligrams semaglutide, which is the target maintenance dose, 22% weight loss. So let me tell you what that means. The average weight on entry to the SURMOUNT trial was 235 pounds. That means the average person on 15 milligrams of tirzepatide, the average weight loss was approximately 50 pounds. Just think about that. Never thought a few years ago we would see anything like this. If we look at 10% weight loss, 90% of people on tirzepatide get 10% weight loss. If we look at 20% weight loss, we see 62% of people on tirzepatide. We wanna, and you wanna, be aware, though, of where that weight loss is coming from. Whether you lose weight loss by medicines or by diet, and look at here, we have on the left side here tirzepatide, on the right side here placebo. They did DEXA scans to look at where the weight loss is coming from in both groups. We have proportionally the same, whether it's by drug or by diet and exercise, the same degree of weight loss from our different compartments. And when we look at tirzepatide, we had 34% weight loss in fat mass and 11% in lean body mass. Same proportion, placebo, of course, less amounts. What does that mean? That means we want to make sure we do what we can to decrease the amount of lean body mass loss. We'll talk more about that in a little bit. All of the trials show about the same thing, that in total, you get about 10% loss in your lean body mass. You get more loss in fat body mass, adipose tissue, and you improve your fat mass to lean body mass ratio. Important also realize our modern anti-obesity medicines, semaglutide and tirzepatide, have really beneficial metabolic effects. We see decreases in LDL, increases in HDL, decrease in glucose and liver fat. We see really a very high decrease in triglycerides. And just a few months ago in the SELECT trial of semaglutide in people with coronary artery disease and obesity, we actually saw decrease in the incidence of what's called MACE, major adverse cardiac events, which is stroke, heart attack, and death due to coronary disease. And we also see improvements in physical function. So these medicines are doing what we wish for. Now, the question that often comes up is, what if you withdraw the medicine? Turns out we are informed by that by two trials, STEP 4 and SURMOUNT-4. One is semaglutide, the other is tirzepatide. And what we see in both is, in both of these trials, they're organized the same way. You had a run-in period on active medicine, semaglutide or tirzepatide, till they were maximally titrated up. On semaglutide, we saw at that point you had 11% weight loss. On tirzepatide, 21% weight loss when they reached their maximum titrated dose. And then that's when the randomization started to continued active drug versus switch to placebo. And what we see is when people are switched to placebo, they start regaining the weight that they had lost. So with semaglutide at the end of 68 weeks, they had regained 7% of the weight that they had lost in the placebo group versus the active group continued to lose weight. You see the numbers on the slide. Same thing in tirzepatide. You see about 14% weight regain at the end of the 88-week trial, whereas on continued semaglutide, you can see continued additional weight loss totaling 26%. Now, what that suggests and what people have said is you have to then be on the medicines for life. I'm not sure I believe that is true because when we look at the drilled down numbers, how did individuals do? Same trial, SURMOUNT 4 here. We see if we look at 10% weight loss as the metric, we see that almost half of the people in the placebo group at the end of 88 weeks still had over 10% weight loss. Now, more than 90% in the active group. But the question that we need to ask together, physicians, nurse practitioners, PAs, dietitians, is there a way that our interventions, can we help people who choose not to stay on the medicines forever, still achieve and sustain significant weight loss? And we see the same thing with step 4 with semaglutide, lower numbers. Okay, we're going to come back to that, and I'll be happy to answer any questions about that. Bariatric surgery, briefly, common procedures, Roux-en-Y, sleeve gastrectomy. We see 30% weight loss. We see 23% weight loss. So where does diet fit in? We know that dietary patterns yield better health outcomes separate from their effect on weight. They also help with weight, but we don't want weight to be our only metric. The Mediterranean diet yields excellent heart-healthy outcomes separate and distinct from its effect on weight. Exercise, same thing, has important healthy outcomes. Weight isn't the only metric. We know that exercise not only improves cardiovascular outcomes, decreases diabetes, but also decreases the incidence of depression and anxiety. It improves osteoporosis. So there's a lot of reasons to encourage exercise. I mentioned the lean body mass loss, and here what I want to say is there's pretty good data to say that the two ways we mitigate lean body mass loss when we have a lot of weight loss is to make sure we have adequate protein intake. And this is difficult because if someone isn't eating a lot, as is true on these medicines, and they're losing weight because of a caloric deficit, getting that 0.8 minimum, right, of 0.8 grams per kilo is not easy. And that average person, and you know this better than I do, you want someone to get between 60 and 80 grams of protein a day to maintain their muscle mass here. That you have to have a thoughtful approach. The other thing, when we talk about exercise, often we focus on aerobic activity. In this case, preservation of lean body mass. We also want to be making sure people are doing resistance exercises. Let's take a few minutes now for questions and answers before we go on to Tyler's part of the talk. Tyler, any questions that have come in that we want to take at this point?
Yeah, absolutely. Yeah. For our midpoint Q&A, I think we have time for maybe 2 or 3 questions. One interesting question that came in, can you speak to the efficacy and safety of anti-obesity medication in children, specifically looking at, I believe, 12 years and up is what they were asking.
Yeah, and that's an excellent question. And what you were nice enough not to say was that there was, adolescents is the only group in whom the new anti-obesity medicines are FDA approved. Specifically, semaglutide for 12 to 18 is approved. And there was an American Academy of Pediatrics guideline that came out in almost exactly a year ago, in February of 23, that actually, in my opinion, had the nerve to say that all adolescents with obesity should be treated with anti-obesity medicines. And I actually wrote a viewpoint that was published in JAMA Pediatrics saying, hold on here. We have a year of data on this. We are underusing anti-obesity medication in adolescents, in my opinion, but it shouldn't be all adolescents who are obese that get these medicines, because we're talking about many of them will be on it for the rest of their life. So we're talking about potentially 70 years on a medication. The other thing when we talk about semaglutide or tirzepatide in adolescents is that we need to be aware that they're not approved in pregnancy. And adolescents, actually over half of adolescent pregnancies are unplanned. Not all adolescents use birth control effectively. So if we're going to choose to use anti-obesity medicines in adolescents, we need to be very careful about emphasizing appropriate birth control. So given those caveats, I think we need to be using anti-obesity medicines more in adolescents. Just the other day, this week, in the office, we saw an 18-year-old who had a BMI of 40. And that is tough. That is tough to address with lifestyle, and for all the reasons that we talked about, obesity is a chronic disease. That person would benefit by an anti-obesity medicine. So we want to, of course, individualize our choices. We want to be using these incredible medicines more than we currently are, but not in everyone. Tyler, other questions? Great question.
Yeah. Let's see here. I guess flipping it to the other end of the life cycle, but is lean body mass loss greater in older adult individuals?
Another really insightful question. We know that older adults over time are at risk for sarcopenia, and we know that as people age, they tend to lose muscle mass. The lean body mass, for instance, in an 85-year-old is proportionally half of what it is in a 50-year-old. So older people are at risk. I think, again, that's another area where we want to be careful about this. If we're going to use, and the definition of elderly is not incredibly clear, right? So there are 60, 65-year-olds that are clearly not elderly. But when we get to 70, 75 and over, we want to make sure, even more than we do in younger people, that we are mitigating lean body mass loss. And if we're talking about 75 and older, I'll tell you personally, I think that I want to make sure that that person is going to be committed to eating an adequate amount of protein and committed to exercise. And I'm going to be a little more stringent in my decisions about who to use weight loss medicines are when someone is over 75 than when they are younger. Great question.
Perfect. Well, I'm gonna take it over here to kind of dive into more of the nutrition aspect. So thank you so much, Dr. Skolnik, for insight and discussion. Awesome. So the first thing we want to talk about is kind of looking at the impact of sugar. So typically we hear our clients say, I need to eat healthier, I need to make healthier choices. And when we talk with our patients or clients and we kind of ask them open-ended questions to dive into this deeper, we would likely see that people want to have maybe more structure with their eating habits and likely consume just an overall higher quality diet. And one way to improve the quality of our diet is by reducing the amount of sugar that we take in. So I did want to take a look at some statistics. So we see from the International Food Information Council, the 2023 Food and Health Survey, 72% of Americans say that they are trying to limit or avoid sugar. And the top reasons for wanting to limit or avoid sugar is to improve the general healthfulness of a person's diet, to avoid gaining weight, to lose weight, and to prevent a future health condition. And we also see that the top reason for not limiting or avoiding sugar is that respondents prefer and like the sweet taste of foods and drinks, which is fair because who doesn't love the sweet taste that we get from sugar? But let's take a look at where our sugar intake is coming from. So this was pulled from the most updated dietary guidelines for Americans, specifically looking at those ages 1 and above in the United States. So as you can see, the largest contributor for added sugar is sugar-sweetened beverages. Sugar-sweetened beverage intake has actually declined since 2002, which is good, but the consumption is still higher than the recommendation. and it continues to stand strong as the top source of added sugar in the United States. So let's compare that consumption versus the recommendation then. So one of the best parts about the dietary guidelines is this breakdown of nutrition through the lifespan. So if we look at each section of the lifespan in the dietary guidelines, we see that the majority are above the recommended amount of added sugar at each stage of life. So even at ages 2 or less, when sugar should be completely avoided, we're still going up above the recommendation. In 2017 to 2018, coincidentally, the average daily intake of added sugar was 17 teaspoons per day for both children 2 and above and adults. And if we compare that to the dietary guidelines, it should be less than 10% of your calories per day. So based on a 2,000 calorie diet, this would be 50 grams or 12 teaspoons per day. If we even look at the American Heart Association, we see the recommendation being less than 6% of calories per day. So for men, that would be 36 grams or less than 9 teaspoons per day. And for women, 25 grams per day or less than 6 teaspoons per day. So that's half the dietary guidelines. So it's really difficult to navigate and really be under the recommendation of added sugar intake if we're not intentional with our nutrition choices. Let's see here. So the impact of sugar. So there was an umbrella review of 73 existing meta-analyses published in 2023. So to kind of give the overview of that, from this umbrella review, we see that sugar intake is associated with a variety of risk factors, including obesity, diabetes, cardiovascular disease, gout, and dental caries. And when looking at cancer specifically, we see that excess sugar intake is a contributing factor to obesity, and we see obesity is associated with various cancers listed here. But let's transition into the talk about different diets, because I'm sure we get that question from our clients all the time, right? Like, what diet should I be on? There's a variety to choose from, and the Academy of Nutrition and Dietetics had a really insightful article published that kind of talks about these different dietary approaches for adults with overweight or obesity. So to kind of give a high-level overview of some of them, we see on the top, we have more of these diets that are focused on protein intake, so higher protein diet, higher protein zone diet. We also see a moderate protein one, which has a little bit less emphasis on protein, higher in carbohydrates. On the bottom row, we see some low-carb diets on the left side, which tend to be talked about in terms of weight management. Difficult part about but we usually see the higher end of those maxing out at approximately 130 grams per day for a low-carb diet. We even see the DASH diet on this list. So this focuses less on percentages and grams and more so hitting these food target groups, which therefore helps with caloric reduction. So it's really an emphasis on making healthful choices or nutrient-dense choices, such as promoting lean proteins, vegetables, nuts, whole grains, low-fat dairy, things of that nature. So I think the major takeaway here is that we know modifying dietary intake is a key component of weight loss or weight management. But dietary approach is not a one-size-fits-all, and regardless of what dietary approach your client decides to take, we see that there are parameters around carbohydrates, and added sugar is going to be part of that conversation, making sweeteners, low no-calorie sweeteners, applicable to any dietary approach taken, especially since we know sugar intake is going beyond the recommended intake levels. So when we look at weight maintenance specifically, the National Weight Control Registry has some interesting statistics. So the NWCR, National Weight Control Registry, has a database of about 10,000 participants. And to be part of this registry, you must be 18 years old, have lost 30 pounds, and maintain weight loss for at least 1 year. And when we compile this data together, we see that participants report these following items for weight loss. So 78% eat breakfast almost every day. 75% report weighing regularly and define this as weighing at least once per week. 90% report engaging in physical activity for about 1 hour per day. And 62% watch less than 10 hours of TV per week. And it really didn't dive into too much separating TV from being on your phone, scrolling social media, but I think it's pretty safe to say that we tend not to be physically active while we're on our phone. So we can likely rope this into the screen time rather than just TV alone. If we focus more on the impact of skipping breakfast too, we see from a systematic review that skipping breakfast is associated with overweight and obesity and can lead to consuming more calories later in the day. and it was also associated with a lower diet quality as measured by a healthy eating index score. But let's dive into the aspects of nutrition that we can educate and make a positive impact on for our clients. So first, the power of protein. So according to the recent dietary guidelines, we do well with meeting our protein intake targets based on age groups broken down in the guidelines. However, we do have a bit of a challenge meeting the recommendations for specific protein subgroups. So 75% of Americans meet or exceed recommendations for meat, poultry, and eggs, but 90% do not meet the recommendation for seafood, and more than 50% do not meet the recommendation for nuts, seeds, and soy products. And the dietary guidelines even broke this protein intake down further, and we see that 43% of all protein foods consumed are consumed as a separate food item. So let's say you have a salad with chicken breast on the side and it's not mixed into the dish. On the other side, 48% of all proteins consumed are part of a mixed dish, with the largest amounts being sandwiches, burgers, and tacos, but could also be things like casseroles too. So we see that the added challenge with mixed dishes as opposed to eating proteins separate is that they typically include a higher amount of saturated fat, sodium, and other ingredients that maybe are not necessarily contributing to a nutrient-dense option. So the guidelines have this emphasis to focus on these subgroups of seafood, beans, peas, and lentils to meet the recommendations of protein, but limiting the processed or high-fat meats that we see, such as hot dogs, sausages, and bacon. And you also get the added benefit of consuming beans, peas, and lentils because we then increase fiber, which is typically a challenge. I would like to review kind of like the protein content of different foods that we see too. So of course we see chicken breast, lean beef, and salmon having the highest amount of protein per serving. And we also have some plant-based options listed here. One of the easier ones that I'm sure we talk about with our patients is peanut butter, just because it's easy to consume, but it really doesn't provide as much protein compared to animal proteins. And usually your typical peanut butter is going to have a couple grams of added sugar and somewhere around 15 to 16 grams of fat, making it more of a calorically dense option. And I'm sure we get this part too, right? How much protein should I eat? And when we get that question, it's not always the easiest to answer because it really depends where someone is at. And I think this becomes a question that's much more important when we think about clients using GLP-1 medications or doing weight loss surgery, because the amount of intake is restricted or appetite will be reduced, and we will have the muscle loss as well as the weight loss. So we have the macronutrient distribution range for protein is 10 to 35% of total calories. And we know the RDA for both men and women is 0.8 grams per kilogram, but the RDA does not necessarily reflect the optimum protein intake, and higher intakes are often recommended to optimize our specific health outcomes that our clients are trying to achieve. So to kind of include some examples here, so for active weight loss following bariatric surgery, we see that a recommended protein intake is 1.2 to 1.5 grams per kilogram per day if we look at the AS/MBS guidelines. And maybe someone in post-op and weight maintenance should likely be consuming somewhere around 1.2 grams per kilogram per day. And we also see a couple of studies that show optimal protein intake is somewhere around 1.2 to 1.6 grams per day. For adults that have overweight or obesity and either have type 2 diabetes, at high risk for type 2 diabetes or prediabetes, we see a recommendation being more at 1 to 1.5 grams per kilogram per day. And I think it's also important to emphasize protein intake because of the risk of sarcopenia associated with weight loss. Whether through medication or surgery, a 2018 study found that those that had a sleeve gastrectomy, which is one of the most common bariatric procedures, had a fourfold increased risk for sarcopenia. And what makes this a little trickier for those undergoing bariatric surgery is that weight loss will happen quickly because of the restricted intake. And I think this is where us as dietitians don't want to give the impression that because someone is losing weight without exercise, that exercise component doesn't matter or it's not important, because exercise is such a crucial tool to prevent sarcopenia. And to kind of tie this together, it could be a point of discussion with our patients to ask, well, how much protein should I eat? We can kind of make things simple and even look at some research showing 30 grams per meal of quality protein coupled with resistance training, because we want people to maintain their lean tissue muscle while weight is dropping, and which is why we need to communicate the importance of protein in the diet to our clients. So even if or when they come off GLP-1 medications, it's still important just to keep up with our daily protein intake. What about carbohydrates? So the discussion of carbs became popular more so recently with the keto diet when that became popular. And I think we frequently have to remind our patients that a low-carb diet does not necessarily mean keto, because it's really this emphasis high in fat, moderate protein, and very low in carb, which gives the impression that carbohydrates are bad for weight loss, which isn't necessarily the case. So carbohydrates add essential nutrients to our diet, thiamine, folate, fiber, among others. But having a discussion around portion control is important, especially when we think about high-carb foods that are easy to snack on, easy to consume, and don't contribute to a higher quality diet. And I think this is an area where people are very visual and respond better to seeing exact portion sizes, whether through measuring cups or just really getting people familiar with nutrition labels to identify an actual serving size, how many carbs are in a serving, and then looking at that added sugar component too. Promoting more healthful choices of carbs is important as well. So we can focus on the slogan from My Plate, make half your grains whole grains, which I'm sure we've all heard before and probably said to our clients. And another way to improve the quality of our diet is by reducing the amount of sugar, which is how low no-calorie sweeteners can fit into the equation when talking about carbohydrates. One study I wanted to highlight here kind of makes us think more about the importance of changing our carbohydrate intake to see benefits for weight. This study had a sample size of over 136,000 people, and they measured weight change in a 4-year period. And on average, participants in the study gained 1.5 kilograms every 4 years, amounting to 8.8 kilograms after 24 years. It was also found that increases in consumption of starch, added sugar, carbohydrates from refined grains, and starchy vegetables over a 4-year period were associated with greater weight gain. On the contrary, increases in fiber and carbohydrates from whole grains, fruit, and non-starchy vegetables was associated with less weight gain. And these associations were larger among participants with overweight and obesity. So this highlights the importance of the quality of carbohydrates that we consume for long-term weight management. And we know there's several benefits to consuming adequate fiber each day, and some of those benefits we see are improved digestive health, reduced risk for heart disease, stroke, hypertension, obesity, type 2 diabetes, and certain cancers. Even knowing these benefits, though, only 5% of the population meets the recommended intake for fiber. And clients may report that appetite is increasing if they are no longer taking weight loss medications, or perhaps when they progress out from bariatric surgery and then can therefore tolerate a higher volume of food. But we see in a 2019 systematic review that found soluble fiber slows gastric emptying, increases perceived satiety, and plays a significant role in appetite regulation, really making it a great addition to the diet that we should be talking to our clients about. And even some clients on GLP-1 medications may have certain side effects, such as constipation or diarrhea, which fiber can also help with. So I listed here again some fiber content of common foods. So we see things on there with a higher fiber content like raspberries and pinto beans. And we, of course, have some more trendy things on there like avocado and chia seeds. But we actually get the bonus of protein and fiber too when we look at things like chia seeds or black beans too. And of course, we can't talk about fiber and neglect the importance of fluid. So we see the adequate intake level for fluid is 2.7 liters for women, 3.7 liters for men. And for post-op surgical weight loss, we have a guidance showing 48 to 64 fluid ounces per day. There is a risk of dehydration following bariatric surgery, which is why this population group needs to be super mindful of fluid intake. And those on GLP-1 medications also need to be mindful of fluid intake since the perception for thirst is reduced along with appetite. We can also see the estimated fluid intake for a healthy person is 1 milliliter per calorie consumed. If we also consider our clients that are going to start exercising more too, especially as part of this new lifestyle change, we need to educate on meeting fluid needs to prevent dehydration. We can even educate on types of foods that have a higher water content that are nutrient-dense options too. So we have some of those listed here. And then to give the importance of hydration greater perspective, I think it's good to share some potential examples of how calories can add up in your day when talking about hydration and sugary drinks. So these aren't necessarily real-life examples or specific to any type of drink in particular, but perhaps you're working with a client that has a higher intake of sugar-sweetened drinks. So let's take some coffee drinks, for example. obviously there's a lot of variables at play when we think about coffee, just because everyone just does it pretty differently. But let's say a typical drink has milk or a milk alternative, some flavored coffee syrup, throw in a packet or two of sugar. I mean, we can see about 150 calories per drink pretty easily, and let's say they have a couple of those per day. Over the course of the month, we're going to look at around 9,000 calories. If we take soda, a can has somewhere around 140 calories. Let's say we have some clients that maybe drink 3 cans per day. We're going to add up to over 12,000 calories per month. Sweet tea is pretty similar to soda in caloric and sugar content with 120 calories per serving. Let's say, again, someone has 3 servings per day. They're somewhere around 11,000 calories. But I mentioned this earlier, but it's kind of the perfect tie-in. So if we look at information from the International Food Information Council, we see that people want to limit and avoid sugar, but really struggle with reducing it because of the preference for the sweet taste. But that's, I think, where we see the benefit in using low and no calorie sweeteners, because you still get this great same sweet taste without compromising your health goals. And in fact, we even see research that shows when we replace beverages that are sugar sweetened with low no calorie sweetened beverages, there are reductions in body weight, body mass index, obesity incidence, and percent body fat, which is really good news for our clients that prefer the sweet taste but don't want the calories. And we're obviously wanting people to consume water as the main fluid, but for our clients that simply don't like the taste of water, low no calorie sweeteners are beneficial to replace sugary drinks. And the Standards of Care in Diabetes agrees that water is recommended over nutritive and non-nutritive sweetened beverages, but the use of low no calorie sweeteners as a replacement for sugar sweetened beverages is acceptable if it reduces overall calorie and carbohydrate intake. So we typically think of low no calorie sweeteners solely for beverages, but they actually have a pretty vast use far beyond just drinks. So for the sake of time, I'm just going to do a kind of a brief overview of some great recipes part of this presentation that are also able to be downloaded too. So let's take one example of a spicy Korean cucumber salad. So we can put this in place of other cucumber dishes that tend to have a lot of fat or a lot of sugar. And from this recipe, we see that 1 serving of 2/3 cups has 80 calories, 5 grams of fat, 2 grams of fiber, and 0 grams of added sugar. A baked teriyaki chicken dish, so another great dish to really promote protein intake. So rather than choosing a teriyaki sauce that has a lot of carbs and sugar, we can use low no calorie sweeteners as an alternative and still get a great tasting result. And finally, I'm sure we've worked with several clients that have expressed concern maybe about going to social events and having something to drink without feeling like they're missing out. So I think mocktails have really become just this great addition. And we see one example here, a cucumber basil mocktail, only 5 calories per serving, 0 grams of added sugar, making it great, refreshing drink and really promotes hydration as well. And because sweeteners, they've been in the news, so I do want to do a brief review, kind of addressing some concerns that we hear about sweeteners in the news today. So first off, we have this study regarding erythritol. So your patients may be coming to you and saying, I heard erythritol is linked to heart attack and stroke. On the right column here, we see some quick responses that you can reassure your clients or patients about the details of the study, but I know we're dietitians and healthcare professionals, so we want to see more of the details. So we know that the study on erythritol was observational, and in fact, authors only included those who were already at risk for cardiovascular events and did not establish dietary erythritol as this cause for cardiovascular disease risk. And on top of that, there was no control for or intervention on diet, physical activity, or other factors that have an impact on cardiovascular disease risk or cardiovascular health. The erythritol dose given was 3 times the max amount found in beverages, and when they measured plasma levels, they were only measured 1 time in the study, and it stated erythritol is artificial when it actually isn't. Erythritol is naturally found in foods such as fruits and vegetables, and it's actually produced by the body when under oxidative stress, regardless of dietary intake. And the sample population of the study only included people at an increased risk for cardiovascular events that had naturally elevated erythritol levels to begin with. When they had participants consume a beverage that had a high amount of erythritol in it, they only had 8 participants, which is a pretty low amount to make conclusions from. And erythritol has been reviewed for safety by the Food and Agricultural Organization and the World Health Organization Joint Expert Committee on Food Additives, and it's approved for use in over 60 countries. So erythritol, like every other low no-calorie sweetener, it's put through this rigorous approval process, and it's only approved when there is strong evidence of no safety concerns. In May 2023, the World Health Organization published an article stating, World Health Organization advises not to use non-sugar sweeteners for weight control in newly released guidelines. But again, let's take a look at that in a little bit more detail. The statements report that these findings are considered low certainty and conditional, and it was not an assessment on the safety of low and no calorie sweeteners. And also this article that was published has been criticized for excluding some pretty large cohort studies that showed benefits of replacing sugar-sweetened beverages with low no-calorie sweeteners. And one of the most important takeaways is that the disease outcomes might have been confounded by baseline characteristics of participants in the study. So, for example, participants with the highest intake of low no-calorie sweeteners tend to have a higher body mass index or metabolic risk factors, and therefore may have been predisposed to chronic disease. And the World Health Organization even noted that reverse causation may have contributed to one or more of these associations observed. And again, because of the lack of certainty, it was considered a conditional recommendation, and it was not a safety assessment. And finally, gut health. Gut health it's just a hot topic among kind of like the world, honestly. And I'm sure all dietitians can name a handful of times they've been asked about gut health and perhaps how low no-calorie sweeteners potentially impact gut health. So if we look at that in a little bit more detail here, so this slide in total has references from 3 great sources that really nails down the fact that low and no-calorie sweeteners are safe and do not negatively impact gut health. One article in 2019 shows that there's no credible evidence that low no-calorie sweeteners adversely affect health through an effect on gut microbiome, and even found clear evidence that changes unrelated to low no-calorie sweetener consumption are the major determinants of change in microbiota. And another study found that sucralose specifically does not cause measurable changes in gut microbiota. And I'm actually really excited to share a recent article that was published very recently, and it really showed that doses of low no-calorie sweeteners used, or when they studied this, doses of low no-calorie sweeteners were based on actual intakes in amounts that are generally included in foods and beverages. And the samples were taken from co-living adults consuming a similar diet to lower potential variations in long-term diet and environment, which is a major driver of microbiota composition. And the key takeaways of the study were that sucralose had no effect on short-chain fatty acid consumption and gut microbiome. And stevia was found to have a beneficial impact on gut microbiota and increase the density of health-supporting bacteria with production of short-chain fatty acids. So in total, I appreciate this final point that safety databases have been developed over the course of decades, indicate that low no-calorie sweeteners as a group or individually pose no safety concerns at their currently approved levels. And so with that, we have our summary slides here. So obesity is now viewed as a chronic condition. The new weight loss medications are highly effective at facilitating weight loss, and proper nutrition is still an essential component of care. And carbohydrates, protein, fiber, hydration are all key areas to help clients improve the quality of their diet. And low no-calorie sweeteners are a safe tool used as part of a comprehensive approach to weight loss and weight management. And with that, we're going to do our second round of Q&A. Dr. Skolnik, do you have any questions that you want to start with?
There are a couple of thoughts and then questions from the audience. One, Tyler, that was great. Thank you so much. You know, it's interesting. 2 thoughts on what you said. One, I did a back of the envelope calculation. Thank you so much for giving the calories per a few servings of a soda and how many calories that was per month. And I multiplied that times 12. And, the soda drinking 3 cans a day for a month, then you multiply it by 12, came out to 144,000 calories a year. And there are a lot of people who drink 2-3 sodas a day. Now, we all remember that number, and it never lines up perfectly, of 3,500 calories per pound. So if you divide 3,500 calories into 144,000 calories, that's over 30 pounds of potential weight gain that can be attributed to just drinking liquids that have no health benefit and only harm. And because the data on sugar and its relationship to adverse outcomes is robust. So I just thought I would emphasize that point, that the opportunity to move toward no-calorie liquids is enormous, and for some people, it's actually critical. Tyler, I saw a patient in the office a few weeks ago who came in to address weight issues, and we went through, actually my resident went through diet in detail, and she was eating healthy. She organic, really healthy diet. And I walked in and I said, "What are you drinking?" And she was drinking 3 large bottles of organic cranberry juice daily. That's incredibly caloric. So just your point about liquids is so important. The other point I just wanted to comment on, and then we'll get to questions, is the World Health Organization got its statement on low and no calorie sweeteners, and it was handled terribly in the press, because what they said, as you said, was that we shouldn't use low and no calorie sweeteners as a means of achieving weight loss. That was the comment, that was their statement that was given a conditional, which means low level of evidence. Unfortunately, what that got translated to in the lay media was you shouldn't use low and no calorie sweeteners. And they just didn't say that. They didn't say that at all. They acknowledged that the difference between randomized trial data, which does show weight loss with low and no calorie sweeteners, but those studies run from anywhere from 12 months to usually 12 months. And the observational trials that does not support that outcome. Now, observational trials, of course, everyone here knows, is subject to confounding, and specifically, when you look at long-term observational studies, do people who use low-calorie sweeteners or diet soda gain weight more than those who don't? People who tend to choose diet soda are people who are struggling with weight issues. So that there's that confounding variable. And so the World Health Organization acknowledged not the confusion, but the difference between randomized trials, observational trials, and came up with this statement that was handled terribly in the press. So we need to make sure that our patients understand that the World Health Organization still endorsed safety. They just said we can't rely on it to achieve weight loss. So I wanted to make sure our audience understand that. I know you said it. I thought it was worth emphasis. Tyler, let's now go with our 8 minutes remaining to questions from our audience. There was a question asking whether you could address something that has been talked about a lot, the relationship between low and no calorie sweeteners and cancer. Can you comment on that?
Yeah, I mean, it's a great question. I mean, like, low and no calorie sweeteners have been around for a very long time, and in the totality of evidence, you know, when we look at systematic reviews or meta-analyses, we just aren't seeing the connection when they test low and no calorie sweeteners and risk of cancer. I mean, safety it's by far the most important thing, which is why these sweeteners are just put through, you know, a pretty rigorous safety and regulation process, and rightfully so. But because they're rigorously tested, they become some of the most researched ingredients in the world, and we just aren't seeing that connection between cancer and low no calorie sweeteners. There was an article from the International Agency for Research on Cancer, IARC, and they did the aspartame and hazard risk. But even when they tested aspartame and hazard risk, the evidence was limited, and they even said it was not convincing. But yeah, you know, sweeteners have been around for a long time, so we would start to see that connection of sweeteners and cancer at this point, if it was a concern.
What a good answer. And I want to take it even a step further. When we think about the way that the U.S. Department of Health looks at low and no calorie sweeteners, it's actually broader and more rigorous than even the FDA does with medications, and that is incredibly rigorous. Remember, when we look at medications, the FDA looks differently at adults, at adolescents, and children with regard to safety, and looks separately at women who are pregnant. And medicines are then approved, segmented by safety and efficacy, of course, but safety, they might be safe in one group but not in another. We talked about that with regard to GLP-1s. They're not approved for use in children, haven't been looked at there. Low and no calorie sweeteners across the board have been deemed safe actually across the board, so even in children. And they look at levels. Remember, with medicines, very careful dosing. You don't use above the exact dose that is prescribed. In low and no calorie sweeteners, they actually, when they talk about safety, they give a margin of error and include safety to, and I'm forgetting the exact number, it's like tenfold greater than what the average person would ever encounter in real life. So the margin of safety is large in the approval process. Let me take some other questions. There are a whole bunch of questions about the GLP-1s. Is that okay, Tyler?
Yeah, absolutely. Absolutely.
And, one of the questions a few people asked about, are there any adverse effects? So and that's so critically important. The main adverse effects are the ones that you see, which are about a third of people will get some nausea, stomach upset, constipation, diarrhea, occasionally vomiting for initially the first month, and that usually then becomes less and less over the course of 3 months. It's usually graded as about mild to moderate in nature, but by the end of 3 months, only about 5% of people continue having that problem. Rarely there can be dehydration, and Tyler, your point about hydration was so important. There have been reports of acute kidney failure due to dehydration because people's thirst mechanism is so off. We have to emphasize making sure people stay hydrated enough. That's an important part of our advice. There are rare reports of more severe GI reactions, again, to be aware of. But in terms of other adverse events, rarely you can have anaphylaxis to any medication, tiny incidence of increase in gallbladder disease. But for the most part, these are medicines that are not only safe, but metabolically healthy.
There was another great question too, and maybe this is more in terms of emerging evidence or what they'll study later on, but do you know of any research that says anything about mental health and these medications?
Yeah, they're part of the warnings in the label is to be aware of the potential for suicidality. Now that is in the label for all weight loss medicines, and it doesn't seem necessarily to be a direct relationship, though we don't know. And it might have something to do also with a great degree of weight loss, changes in body image. That said, it's something to be aware of, whether it is medicine-induced or whether it's secondary to the change in body image that comes with large degrees of weight loss, to be sensitive to and ask about suicidality, particularly in patients who are suffering from depression. And I think we really should be attentive to issues around change in self-image when we change weight to this degree.
Yeah, absolutely. And there was another one, trying to find this other question. I guess I'll kind of take this one, but there's a recent article suggesting that artificial sweeteners are linked to AFib, and kind of asking for a comment on that one. Yes, I think that came out last week. It's definitely maybe hypothesis generating. It was an observational study, but I'd be really hard pressed to say this is anything we should be changing recommendations over until we see it replicated. So there is reverse causation, which is a lot of case for these observational studies. And the study participants did have comorbidities such as smoking, high BMI, and type 2 diabetes, which are all established risk factors for atrial fibrillation. But we also see, on the other hand, systematic reviews and meta-analyses that show low and low-calorie sweeteners are safe and actually show some benefit for cardiometabolic health when we use sweeteners in places of things like sugar-sweetened beverages. So I touched on this in my presentation. I mean, we want people to drink water, but there's just some people that they don't like the taste of water and won't drink it, and instead will have a sugar-sweetened beverages. So this is kind of where sweeteners can really help people have, something more flavorful than water, kind of without compromising their clients' health goals.
Yeah, Tyler, I think that's the big take-home point, that there's a range of safety, a range of what we would like. In an ideal world, everyone drinks some water with maybe a squeeze of lemon. None of us live in an ideal world, and we know that sugar is evil. The data you presented on the downstream effects of sugar is enormous, and so low-calorie and no-calorie sweeteners fit into that if you want that sweet taste and avoiding all those calories and problems with sugar. Tyler, this has been such a pleasure to present with you.
Absolutely. Leslie, we'll have you take it over here.
Excellent. Thank you, guys. That was awesome. A lot of information in not a lot of time, so I appreciate you sharing your expertise and doing it so efficiently. We were really glad to partner with you on this event.
Thank you.
And so, as we do every day, or every webinar, I should say, at this point in time, we can talk about what's coming up next on our webinar calendar. On Tuesday, April 9th, so we're talking about next month, from 2 to 3:30 Eastern Time for a credit and a half, learn about metabolic dysfunction-associated steatotic liver disease, or MASLD, and what you and I know to formerly be called NAFLD. Christine Randazzo-Kirshner and Dr. Mesa El-Zagbi are going to put on an interprofessional webinar, so you're getting the RD and the MD perspective here again. And they're going to provide an overview of MASLD and discuss how an interdisciplinary approach can provide the best outcomes in reducing liver and cardiovascular morbidity and mortality in patients who are suffering from MASLD. Register today at ce.todaysdietitian.com/webinars, and that one will be the first one in the live webinar list. And finally, the credit claiming email will be sent out within the next 24 hours, likely sooner than that. The presentation handouts were emailed to you earlier today. If you didn't receive them or you had problems downloading those, the links to download the handouts will be included again in the credit claiming email. I know a lot of folks are really excited for the recipes that Tyler reviewed. Those are an additional handout that you can download and enjoy. And so that will be coming out within the next day or so. So thanks again, Dr. Skolnik. Thanks, Tyler. And thanks, everyone, for joining us. Have a great rest of your day, and we'll see you on April 9th for our webinar on MASLD.